Okay, welcome back for this session, which has the impenetrable title of Cost Considerations Ensuring the Best Returns on Investment while Ensuring Sustainability and Diversification. I don't know how you could get more into the title or more that I have less to contribute to the subject of, but I will do my very best. But the key speaker for this session is Dr. Vichai Chokevivat from Thailand, who's an extraordinarily distinguished scientist and scholar. He was Secretary General of the Food and Drug Administration there, Secretary General of the Medical Council there, and he is currently Chairman of the Board of Governors for the Pharmaceutical Organization in Thailand. And I know we'll have a lot to tell us and inform us about the vaccine programs in Thailand. So, I was asked to give a set of hopefully not totally incoherent remarks on this broad subject, and I've sort of broken it into three areas to comment on, and the economic costs as they are perceived, the economic risks and benefits in vaccines, and most, I think, relevant to the sustainability, a few words about innovative finance mechanisms for developing country vaccines that are existent and potential. Next. Can we get to the next? So how do we know how serious a pandemic is? And what you end up reading about turns out not to be awfully helpful from an economic point of view, which is the number of people who die in each of these outbreaks or epidemics or pandemics. We know that 1918 is the prototype. That's what's in everybody's mind. It's the referent. And we know that there are now something like 3 times more people in the world. We have airplanes. So whatever the dangers were in 1918, we obviously know are much, much greater now. And just looking at the dates of spread of SARS in 2001, 2, and 3, and the recent epidemic in the last few months, flu gets around the world very quickly. So we don't have a lot of time to think about what's important. Putting together data that was published at the time and then some recent papers in health policy on the costs of SARS, there were 2 general points. The first is that it cost a lot of money in loss of a variety of measures, in this case, economic measures on annual growth or GDP. There's also a concern that at the time, much of these are projections, and that the projections overstated the case. But the ranges are broad enough so that it's probably not unreasonable that this costs billions and billions of dollars, particularly for the Asian region countries. On the other hand, the extraordinary thing is thereafter the economies boomed. So these were temporary setbacks of a significant magnitude for the countries, but within certainly months, and then within 2 years or 1 year afterwards, the economies boomed. I would put it in the framework, if we had such an outbreak now with the economies around the world strapped, the outcomes might not be so transient. Now I'm going the wrong way, guys. In this country, the best minds were brought to Washington to figure out what a pandemic would look like. And these are some of the numbers. And the estimates were that a mild pandemic would cost 1% of GDP, and a severe pandemic would cost something like 5% of GDP, which are colossal numbers. We are at the tail end of an existing pandemic, and those numbers seem awfully high to me. So the question is, how do we know how serious a pandemic is? And I would say that we don't know how to do that very well, which from an economic point of view makes real assessments difficult, and from an epidemiological point of view really requires some learning from the last experience that might be useful in the future. So on May 4th, in Mexico, there were a certain number of confirmed cases, but the fatalities, and very few countries miss people who die. They're counted very well. The case fatality rate that appeared in the press and in medical correspondence was 4%, a devastating epidemic of enormous power. In the US, similar date, maybe 0.1% case fatality as a measure of severity. And then there are the big problems of censoring bias, missing people who are dead, and even more serious detection of mild cases. Very, very challenging. Except for the Europeans, everybody was way off as far as I can tell. So here's the pyramid that we study in this country and would be representative elsewhere. And what we measure and what the press sees is the number of people who are dead. And what we have very little capacity to put together, and as you can see from the arrows, these data were put together by a team assembled by CDC, WHO, and the UK. Data from Wisconsin was the only state that measured people who went from a doctor to a hospital. Then you measure hospital people. We have no way really to go from the bottom, the number of people who are symptomatic or serologically infected, to the number of people dead, to get a measure of the severity. And when the estimates were made on the US here, it wasn't 4%, it wasn't 0.1%. It was on the order of 0.005 to 0.009%, so that in retrospect, the H1N1 turned out to be even more milder than we were calculating as a mild flu, yet it was hugely transmissible in a very short period of time. So to make economic assessments of the burden of this disease, one has to get better epidemiological data, particularly from people who are symptomatic, and that means a systematic way of doing that. There have been a couple of papers published on how one could do that. The relevant point is by sampling data and setting up in advance in developing countries, these data could be relatively easily generated, at least in my view. Now, everybody is worried about resource allocations, which depends largely on things like cost effectiveness. So the standard analysis, these are from the Office of Technology Assessment, 1981, what the US government considers in its cost effectiveness of an intervention like a flu vaccine, is efficacy, cost of vaccination, and medical costs averted, or conditions that would result from the disease long term. And those are not unreasonable. But if one looks in a more serious way at the cost effectiveness of vaccines, particularly childhood vaccines, my colleagues David Bloom and David Cutler for Gavi have looked at the impact on a variety of other parameters, like the impact on childhood education, productivity, labor markets and wages, impact on fertility as to whether kids died or not in childhood, impact on savings as to where people were using disposable income, and even in countries on direct foreign investments. That is, infectious diseases have far greater economic impact than we usually measure in simply measuring medical costs and making a judgment, are the vaccines cost effective or not? So what we'd all like to see is this kind of picture of the cost benefits of vaccines, of how we save $32 for 20 days of not having to give smallpox vaccine, $21 for MMR, and these are wonderful data, but they're not likely to be simple like that for flu. So the costs of seasonal influenza, there are lots of papers, and one of the problems is depending on the economists and the assumptions, they get very different answers. And so in this analysis, in the dollar cost of the influenza epidemic, what they would say is it costs $12 billion so far in this country. If you put all the papers that I've read, which is not all that are written there, there's some really very simple truths, and the dollar facts don't seem to mean very much, at least to me. No matter how you slice it, at almost any price, kids at risk it would be a tremendously cost-effective and cost-beneficial bargain to give them vaccine. It is variable in terms of cost-effectiveness on any other healthy population, mostly determined by how many kids at risk in any population there are and the cost of the vaccine, and it's very sensitive to the cost of the vaccine. So one has to know that if we're trying to do the economic best thing, which is to make it cost-effective or beneficial, the cost of the vaccine is a significant parameter. Clearly, okay. Another place to look, and I only found one reference on this, and I think it's probably wrong in terms of its quantitative nature, but it says the private sector has a real interest in influenza vaccines, which they don't in childhood vaccines. And this is a report from an oil company in Malaysia showing that vaccinating their staff based on days of work and productivity lost turned out to be a real bargain. We should, I think, be mobilizing more data from the private sector to convince them to become participants in this exercise. These are data well known to you, and that is that when you look at the childhood vaccine markets, the proprietary market is a very small part of the vaccines that are produced, and then there are various different differential prices and tiered pricing all the way down to the UNICEF price. So this established that if one wants to look at the issue of the price sensitivity of cost effectiveness, one also has to look seriously at the cost of vaccines and who the populations are. And the second point is that new vaccines cost a great deal more than old vaccines because they're harder to make. And in the case of flu, they're being made by an absolutely arcane procedure and not the greatest efficiency that we would hope science could bring. But the public is used to, even in developing countries, DPT and MMR, the cheapest possible vaccines. And they're going to have a sticker shock when new vaccines for anything come about. Finally, when one looks at something that, again, the public, I think, is relatively unaware of, vaccines are hugely risky at every single level, whether it's at the discovery level, the R&D level, the capacity problems, the scale-up problems, regulatory problems. There are risks at every single level, huge money sunk into facilities, production capacity, where one bad vaccine or one bad clinical trial could wipe out a giant investment. And I think then that one of the issues that we're hearing here and BARDA is committed to doing is how to minimize those risks, particularly in developing countries, to provide guidance on how to solve some of these problems. And in this context, I would mention that the UNDP in 1994 created an International Vaccine Institute. It's located in Korea, and its purpose only is to work on vaccines relevant to the poorest countries and the poorest populations. And they do have expertise and have provided a lot of training, particularly in Asia, run clinical trials and particularly effectiveness trials as opposed to efficacy trials, how do vaccines really work in real countries where the populations are dispersed and difficult to study. So I would hope they could become partners at some level with BARDA. Now let me switch to the sustainability issue and be pretty encouraging. There is a tremendous increase in funding for global health over the last 20 years, basically. Tremendous increases. And among the most striking things are the increases are not just what used to be the bilateral donors, the countries, but there are a whole new series of actors, whether it's rollback malaria or Gavi or many other organizations. The other intergovernmental agencies like the World Bank are now major players in the area of health that they shunned before. So that's very good news. We've gone to a level of all overseas development assistance to something like $22 billion. How sustainable that will be, I don't know, but there's more money to buy more health in developing countries than ever before. I think another interesting aspect is a big chunk of that money, perhaps 40%, is not dollars, but development assistance in-kind gifts of things like vaccines and drugs and capacity building and training. So there's another framework of particular relevance to developing countries that augurs well. On the other hand, with all of those agencies harassing the countries that are borrowing or writing grants, this is the picture of life from the Minister of Health of an East African country. Every one of those circles provides money. Everyone requires accountability, and none of the accountability is uniform or standard, such that one country decided that, which had 1,200 site visitors in a year, decided that for health, I don't know about the rest, decided it would close its borders to site visitors for 3 months so they could get on the mundane business of protecting the health of their people. This is shameful, and if the U.S. government could get its act together and lead other countries to some kind of harmonization of requirements for accounting for health aid, that would be terrific. And finally, the perhaps most optimistic thing I can say about particularly sustainable financing is there has been something in the last 5 years that you would have to put in a category we never thought about before called innovative financing for health. And these are the ones that I know about. There may be others embryonic that are out there. And I'll say a little bit just about a couple of them and then happy to answer questions. The first was coming from Gordon Brown in the UK. Why not set up a trust fund, in essence, a priori, to support vaccines for kids, for Gavi, by essentially raising bonds on the commercial market and letting governments put money up front to make the vaccines and immunization possible. And the logic is that when you get vaccines out early, you'll need less and less money in future because you'll have less and less of any disease. And this has quite a significant amount of money and two great things. One is it has only, I think, no or 6 employees. So this is not a huge bureaucracy, and yet it controls a very large amount of money, something on the order of aimed for 53 billion. They don't have that now over 20 years. So that's a new mechanism, creating bonds in the commercial market that sets up the equivalent of a trust fund. The second was created by a guy named Michael Kramer, an economist at Harvard, and this is the idea of advanced market commitments. One of the problems of developing new vaccines is, do you have a market? Will you get your investment back? So this is a phenomenon where if you have a new vaccine and can persuade people that it's an important one, which has now been done for the first time, the international community would top up the price of the purchase of the vaccine to subsidize the cost to developing countries, to pay the manufacturers and give them enough money to pay off their investments and to make a small amount of profit, probably. But after a fixed period of time, they would have to reduce the price forever for that vaccine to the local market. Very tricky to guess what an appropriate price is. Big hassle. The one case now where this is being used is the pneumococcal vaccine, and we hope that it works. And what it says is if the global community would set up a period of time to subsidize a vaccine, the companies would agree to produce it and provide it at low cost, and hopefully at a cost the countries could purchase. Something similar, I chair a committee at the Global Fund called the Affordable Medicines for Malaria Facility. It's very similar to this. We have one drug left for malaria called artemisinin. If it's used as monotherapy, it will disappear for usefulness. All other monotherapies have failed. So a Nobel laureate economist, a committee at the Institute of Medicine, said, why not put out combination vaccines? WHO made that now as a requirement. The problem is it costs 10 times more than monotherapy. Again, the Global Fund now has a trust fund in essence, created by the international community, not contributed to, unfortunately, by my country, which is now about to launch combination therapy subsidized in 11 countries that will work both through the public markets through government hospitals, but also through the local shop system, which is where most people buy their medicine. And it's the first time I know of where the private sector distribution system is being utilized for global health in a useful way. Unitaid is a private foundation that was set up by an extraordinary man who put the surcharge on airplane tickets in Europe, a very small surcharge that everybody is obliged to pay. And that has raised $1.5 billion for antiretrovirals and subsidy of vaccines for kids, and he believes that that will increase. Something like 20 countries have imposed also voluntary or involuntary taxes on airplane fees to go to health and vaccines, which is an extraordinary participation of developing countries themselves. There is an effort to take bank loans for countries in debt and say that countries will pay off some of their debt provided the money goes into things like vaccines and health. And that opens up a lot for the poorest of poor countries that are badly indebted. The Norwegians and Scandinavians are pushing for a results-based financing. We will give you money if you show us that the money is actually buying health and there are measurable outcomes. Instead of bloating bureaucracies or disappearing, you'll get more money where that came from. A new serious way at looking at continuing financing. The person, Mr. Douze-Blazy, has created an idea for pooling patents where companies that make vaccines and adjuvants, for example, and have separate patents, or different vaccines in combination, would pool their patents for the poorest countries that would save bureaucracy, save money, and make them much more affordable. And there is then another proposal that he has made, which is for all currency transfers between the United States, Europe, and the industrialized world, a tax of 0.005% be added. That would add in 1 year $3 billion that could be dedicated to purposes of health. And his final idea, which is the idea of something called massive good, is to ask people to pay $2, little people, not people who fly on airplanes, all over the world, to create a global fund, in essence, for vaccines, antiretrovirals, and drugs for kids. So in the long run, I think there are greater hopes for sustainability than one might have had 5 years ago. So with that, I will finish my remarks and call on Dr. Vichai to give us some views from his experience in Thailand. Yes.
Good afternoon, ladies and gentlemen. First of all, I would like to thank the organizing committee for inviting me to participate in this workshop. My topic today is economic return versus national security concept, balancing sustainability and cost effectiveness. Now I would like to briefly introduce our organization. The GPO, or the Government Pharmaceutical Organization, is the state enterprise under the Ministry of Public Health, responsible for research and development, production, and distribution of pharmaceutical products throughout the country, mainly to the government sectors. We produce more than 200 items of medicines, not only for treatment, but also for prevention. For example, the JE vaccine and the DPT vaccine. Now I would like to briefly introduce our country. Thailand is located in Southeast Asia with 63.4 million population. The life expectancy is 70 years for male and 76 years for female. GDP for per capita is about $3,200. For the health system in Thailand, we have now 100% coverage of health insurance. The HIV/AIDS patients have free access to the cocktail formula of antiretroviral drugs since 2002, and the renal replacement therapy for end-stage kidney disease since 2007, and also seasonal flu vaccination for high-risk groups in the same year. The number of doctors and beds per 10,000 population is 5 and 16 respectively. Okay. After the second outbreak of the bird flu in 2004, by networking and collaboration among several ministries, the National Strategic Plan has been set up since 2005. The first plan covered the years 2005 to 2007, and now we are in the second plan that covers 2008 to 2010. Following this strategic plan, the Thai government has approved the establishment of industrial influenza vaccine production project by allocated $42 million to secure the socio-economic stability of the country. Due to the difficulty of having technology transfer from the vaccine manufacturers from developed countries, we requested support from the WHO to create research and development in influenza vaccine production. GPO has developed process and QC tests of influenza vaccine from laboratory to pilot plant to pilot scale by WHO grant. First grant in 2007 was $1.996 million. Second grant in 2009 was $2.064 million. As the outbreak of pandemic H1N1 2009, the clinical lot was produced and entered phase 1 study from December 18 last year, and plan to finish phase 2 in April this year. Certain lots of supply has been produced in parallel. For the situation of H1N1 in Thailand, up to the end of November last year, about 12.6 to 15.8% of Thai population has been infected with H1N1, which is approximately 8 to 10 million people now infected. And this is estimated by Bureau of Epidemiology of the Ministry of Public Health. Until the 5th of January 2010, the cumulative numbers of confirmed cases is 29,921 cases, and the cumulative number of deaths is 192 cases. According to the situation, the government decided to import 2 million doses of pandemic inactivated influenza vaccine at the cost of $18 million. The immunization is starting today for our health personnel and among the high-risk group, for example, pregnant women, people with chronic disease. Now I talk about the investment in flu vaccine production. We have developed a pilot plan certified WHO GMP standard for clinical trial lot production of pandemic live attenuated influenza vaccine. At first, the plan was built in order to do research and development of inactivated influenza vaccine in laboratory scale since 2007. we were supported at least $2.05 billion by the WHO and US government. GPO is responsible for management and operating costs of about $500,000 for the laboratory and pilot plant. In parallel, in order to secure the health, social, and economic stability, the industrial influenza vaccine production project has been for inactivated influenza vaccine has been developed. The construction is now ongoing and will be ready for vaccine production in 2012. At start, we hope to produce 2 million doses of trivalent inactivated vaccine annually and increase accordingly to the maximum capacity at 10 million doses annually. The capital investment for this industrial plant is supported by the Thai government, and the GPO itself plans to invest around $8 million for live attenuated influenza vaccine plant. This project is now under consideration of National Economic and Social Development Board and is expected to be finished within 3 years. Now, rationale for investment. The principal rationale for investment is mainly for national security, with additional purpose to support the sub-regional and regional security and for capacity building for self-reliance. The most important policy is that there is no commercial purpose. We have no concrete estimation on the return on investment. The National Health Security, to sustain the factory, the National Health Security Board approved seasonal flu vaccine coverage for high-risk groups since 2008. This will cover 4 million people within 3 years, or by 2011. This decision was followed a study on cost effectiveness of the vaccination among high-risk group in 2 provinces. And the study revealed that flu vaccination is very cost effective and very useful, both to improve quality of life of the people in high-risk group and to reduce workload of our health personnel. The inactivated influenza vaccine plant will start to produce this amount of vaccine in 2012 to respond to local demand. This will allow sustainability and continuity of the capacity. Concerning the status of H1N1 2009 pandemic live attenuated influenza vaccine production, I would like to talk about 4 main issues. First, technology transfer. The pre-master seed used in live attenuated influenza vaccine production was obtained from the Institute of Experimental Medicine, or IEM, of Russia, while the production technology is highly supported by the WHO. Second, the yield. So far, we obtained 15 to 20 doses per egg with the titer of 7.5 log. At the moment, already we have around 1.5 million doses in stock. Third, stability of the vaccine. With the stabilizer used, the concentrated vaccine can be kept at minus 80 degrees Celsius for at least 12 weeks, while the finished vaccine can be kept at minus degrees Celsius and 2 to 8 degrees Celsius for at least 6 weeks. And fourth, clinical trial. We successfully brought our vaccine entering phase 1 clinical trial. The first dose was given to 24 volunteers on 18 December last year. There was no immediate toxicity found. At day 21 after the first dose, the second dose was given to those volunteers on 7th of January this year. We now wait before beginning our vaccine to phase 2 clinical trial to evaluate safety and immunogenicity in 400 volunteers. The phase 2 clinical trial should be started in February this year. The cost of seasonal flu vaccine in our country and the pandemic flu vaccine available in Thailand is shown in the table. The imported one is more expensive than locally produced vaccine, especially for pandemic flu vaccine, estimated to be much cheaper. The imported vaccine costs about $7.35 per dose. Meanwhile, our H1N1 pandemic live attenuated vaccine is roughly estimated to be about $1 per dose. Since GPO is the state enterprise, and most of the money invested in this program are from donation, the GPO board of directors has agreed to donate all H1N1 2009 vaccine to the Thai government at no cost. And GPO committed to share 10% of our vaccine to WHO also at no cost. In conclusion, we thank to the pandemic. Now we are quite confident that we can produce vaccine, but I think we got much more than just a vaccine. First, the Thai government has committed to invest on flu vaccine research and development and production capacity in a sustainable manner. Second, commitment from international partners to support technology transfer to developing countries. For example, WHO supported by US government, ADB, and especially the IEM of Russia. Third, capacity building of the Thai government, of the Thai GPO on the production of the flu vaccine for national security purpose. Finally, increased access to seasonal flu vaccine among Thais. Thank you very much for your attention.
So we do have time for some comments and questions, and there are a number of people here I know quite a lot. Be very happy if Abdullah, perhaps you could make a comment.
Well, first of all, thank you for the opportunity to talk a little bit about some of the things that we've seen with burden of flu. And I think we were talking earlier about this idea when one is looking at the extent of a pandemic, and in the case that we were discussing, actually the burden of seasonal flu, that often is far greater than we think, and that should be factored into any consideration about the cost and benefit, and what really is the real burden. In developing countries, I think it's been largely underestimated just how vast or how great the burden really is. Data that we're finding in Bangladesh and now from other sites indicates that influenza not only is highly endemic and has a high attack rate throughout the year, but very importantly, as was said earlier by one of the speakers this morning, I forget exactly who, it's a substantial cause of childhood pneumonia. We've just published, it's actually not in print, but it's available online in PIDJ, findings from Bangladesh that show that this is a cause of about roughly 10% of all the early childhood pneumonia, that is pneumonias in kids under 5 years of age. It's really very high, both because of the high incidence, but also because roughly 28% of the kids who get the influenza infection progress to pneumonia. In addition to that, these are also areas that have high endemic rates of other causes of childhood pneumonia, such as invasive pneumococcal disease. And of course, there's an interaction between influenza and pneumococcus. So from both of these mechanisms, we probably get a substantial contribution from flu, either directly or indirectly, to the leading cause of childhood death. Because it's been underestimated, flu often isn't discussed. And the last thing I'd just add to that is, you know, again, earlier today, someone was talking about the need to be a bit more thinking out of the box and being a bit more imaginative about how we think about solutions. And I think when it comes to looking at the data, and I think it really needs to be an evidence-based discussion, is if you look at where the burden is in these kids, it seems to provide a window of intervention that we can think about. And that is, rather than thinking about introduction of, let's say, influenza vaccine, perhaps just to treat seasonal flu, think about it as a targeted intervention to prevent childhood pneumonia, primarily to prevent mortality. And in that way, perhaps it can be delivered in a way that, number one, is appealing to developing countries that have high burden, and number two, is something which is sustainable. Rather than chasing, you know, seasonal outbreaks, think about it, for example, as something to give in an age cohort to prevent early childhood death. So there are lots of ways of thinking about this, but the key concept is just that the influenza virus contributes substantially to the burden of childhood disease and is something which has been underestimated.
Thank you. Christina, would you like to make a comment? Anybody?
Yeah, this is Kathy Newsel from PATH.
Kathy,
I think Abdullah said it as well as anybody could, and I think the key point that you made, and it's true in Bangladesh and true in the developing world and absolutely true in the United States, is that absence of surveillance does not equal absence of influenza. And if you think about the steps that you need, there are limitations in our testing practices, there are limitations in our tests, and there are limitations in our reporting. So almost every figure that you see has to be an underestimate if you think through those steps. And as you've just explained nicely, then that affects the cost of your program, et cetera, if what we're hearing are largely underestimates.
Thank you. Dr. Elliott, are you here?
Yes.
Yes, perhaps you could comment.
Thank you, Dr. Bloom. Although I was at Merck for almost 20 years during the 70s, all of the 80s and part of the 90s, we made influenza and pneumococcal vaccines, but we never transferred the technology. But we did have several successful transfers of technology to foreign countries. One of the first was in the late 1980s, where we transferred the technology for the manufacture of live virus attenuated measles vaccine to Brazil, to Butantan. We transferred the technology. I had a group of my people go down and spend some time with them to teach them how to make the bulk vaccine, to do the filling, the testing, and the lyophilization. Then in the early 1990s, we transferred the technology for recombinant hepatitis B vaccine to Singapore. We had a group of scientists from Singapore come over and spend 3 months in my manufacturing area. And then when it was time for them to make vaccine, I sent people over there who also spent a little over 3 months helping them to make the vaccine. And the most ambitious thing we did was transfer the recombinant hepatitis vaccine technology for manufacturing to mainland China. What we actually did was build 2 modular facilities in the United States, take the 2 facilities over into China, set them up, validate all of the equipment, and then transfer the technology for manufacturing the vaccine. We were very fortunate because one of the scientists in our research group that helped develop the vaccine, actually his parents were missionaries to China, so he spoke the language and knew a lot of the customs. So we were able to make vaccine out of that plant and out of the other plants where we transferred the technology.
Are there any other questions? Yes, please.
Just a very quick question. Is there a plan in Thailand now that the the policy for using vaccine is set to monitor the effectiveness of the vaccine program? And can you explain how that will be done? Is there a plan to monitor the effectiveness of the influenza vaccine program?
Yes. When we introduced this program to start flu vaccination, we are requested that we have to do evaluation to expand our program.
But what kind of surveillance do you do to know how effective the program is? What do you measure?
Yeah.
What agency measures the effectiveness?
We have two group in the ministry. One we call the health intervention and technology assessment program to assess to collect the data and evaluate. And this is one group. And also another group is in the Bureau of Epidemiology in the Ministry of Public Health. In the Bureau of Epidemiology, we have a training program we call Free Epidemiology Training Program that follow the EAS program of the CDC. And we work closely with the CDC for a very long time. And CDC has a EID program, Emerging Infectious Disease Program, in a center in Thailand. And we work very closely with the CDC.
That's great. Dr. Padu? Okay, so I think we finished our session, and I thank you for a fascinating presentation. And we will move on, I guess, to a summary discussion.